We are live.
Good evening, everyone. So we are back with the next class of Strabismus and Neuro-Ophthalmology module, and today we have an excellent teacher, and he was my first SR when I joined RP Center as JR. So I welcome Dr. Munish Dhawan sir to this lecture, and I request our coordinator Dr. Pranita Sahai to introduce her, and then we'll move on to the class.
Thank you, sir. So we welcome all of you to the third module of DOS-PEP. Here we are discussing about strabismus and neuro-ophthalmology, and today we are on the 17th lecture of neuro-ophthalmology, and Dr. Manish Dhawan, sir, is going to be talking about a very important subject, that's visual pathway, the relevant anatomy, physiology, and its clinical relevance. In the last class, we have discussed about optic nerve, and sir is going to take us a step forward with discussing about the visual pathway. We have with us the moderator for the session, Dr. Gunjan Saluja, who's been a part of our previous sessions as well. And Dr. Munish Dhawan sir is currently the professor and head of the Guru Gobind Singh Medical College at Faridkot, Punjab. As Dr. Praful has already highlighted, he's done his post-graduation from AIMS New Delhi and senior residency in strabismus and neuro-ophthalmology from AIMS New Delhi. He's presented at various national and international conferences and has over 20 PubMed Index publications in peer-reviewed journals. And on this note, so we welcome you on your talk on the visual pathway, a discussion on the topic.
Share my slides now.
Yes, sir.
Okay.
Yes, sir.
Okay. So, good evening, everyone. At the outset, I would like to thank Delhi Ophthalmological Society and Dr. Praful and Dr. Parinta for a very nice introduction. And my topic for today is the visual pathway and its clinical relevance. So, the slides are visible?
Yes, sir. Slides are visible. We can hear you as well.
Okay. It is not
moving ahead.
Not moving ahead.
Sunil, can you please help, sir?
So these slides are not moving ahead, but what could we do?
Just a minute, sir. Sunil ji?
Yeah.
Yes.
Now it's moving.
Yes, sir.
So now the visual pathway is being constituted by the anatomical structures which transmit the light energy to the electrical potential, which is being interpreted by the brain. So visual pathway, this is some small video in which I have tried to show the right and left eye and the right and left visual field of both the eyes. So as we can see that any stimulus in the temporal area of the right side visual field, it will stimulate the nasal retina of the right eye, and any stimulus in the nasal portion of the right side visual field will stimulate the temporal area of the right eye. Similarly, it happens with the other eye, and the central part is the binocular visual field, and foveal representation will be there in the central region. So when the signal transmits from the retina, they form the optic nerves. So this is the right optic nerve and the left optic nerve. These two optic nerves travel in the brain and they decussate at the level of the optic chiasm. At the level of the optic chiasm, the nasal fibers from the both eyes, they go to the contralateral side, they form the right and left optic tract, whereas the temporal fibers remain on the same side. These optic tracts end up in the lateral geniculate nucleus. From the lateral geniculate nucleus, optic radiations transmits the visual stimulus up to the occipital cortex. So this is the gross representation of the visual field. We will study in detail in the further slides. So visual pathway is grossly divided into three regions. One is the prechiasmal region, next is the optichiasmal region, and the third is the retrochiasmal region. In prechiasmal region is being constituted by axons extending from the retina and forming the optic nerves. At the level of the optic chiasma, the right and left optic nerves join and they decussate, and the nasal fibers from the right side, they go to the left optic tract, and the nasal fibers from the left side go to the right optic tract. Then comes the retrochiasmal region, which lies between the optic chiasma and the primary visual cortex. Now coming to the components of the visual pathway. As we have already seen that it starts from the neuroepithelial layer of the retina, then they form the optic nerve. These optic nerves, right and left, decussate at the level of the optic chiasm, where, as I already told, nasal fibers go to the other side, contralateral side, and temporal fibers remain on the same side to form the optic tract. These optic tract end up in the lateral geniculate body. From the lateral geniculate body, optic radiations transfers the visual stimulus up to the occipital cortex. So, coming to the various components of the visual pathway, optic nerve is the first component of the visual pathway. So, optic nerve is being constituted by the 1 million myelinated axons from the retinal ganglion cells, which come together at the level of the optic disc to form the optic nerve. Fibers of the optic nerve are myelinated by oligodendrocytes. It is comparable with the white matter of the brain. It is also considered as the outgrowth of the brain. Unlike peripheral nerves, it is not covered by the lemma and it is surrounded by meninges. Optic nerve is again divided into four portions. First is the intraocular, which is 1 millimeter in length. Next is the intraorbital, which is around 25 to 30 millimeter in length. Next is the intracanalicular and intracranial portions of the optic nerve, which are around 10 millimeter each in length. Intraocular portion of the optic nerve passes through the sclera, choroid, and appears in the eye as optic disc. The diameter is around 1.5 millimeter, which expands to 3 millimeter just behind the eye because of the acquisition of the myelin sheath. Optic nerve head has four portions. So first is the superficial nerve fiber layer, next is the prelaminar region, third is the laminar region, and fourth is the retrolaminar region. Superficial nerve fiber layer has unmyelinated axons which are richly vascular. They forms the neuroretinal rim. Next comes the prelaminar region, in which dense glial tissue in the form of astrocytes uh, structurally support these axons. Fibers are being separated before entering into the lamina cribrosa. Lamina cribrosa is a sieve-like collagen plate through which axons pass, and it is a site of glaucomatous damage also. Myelination of the optic nerve starts at the level of lamina cribrosa only. After the lamina cribrosa, there is a retrolaminar region where axons become myelinated, thickness is increased. That is why posterior diameter is more, around 3 millimeter, as compared to the optic nerve head diameter, which is around 1.5 millimeter. It is surrounded by meninges. Next component or next portion of the optic nerve is the intraorbital portion of the optic nerve. It is around 25 to 30 millimeter in length. It extends from the back of the eyeball up to the level of the optic foramina and covered by the dura, arachnoid, and pia. At the level of the optic foramina, fibers of the superior rectus and middle rectus muscle are adherent to the sheath. That is why whenever there is inflammatory condition of the optic nerve, like optic neuritis, there is involvement of these muscles and there is pain in the extraocular movement. Next comes the intracanalicular portion of the optic nerve, which is around 6 to 9 millimeter in length, and this portion is closely related to the ophthalmic artery. In the intracanalicular portion of the optic nerve, pia mater is closely adherent to the optic nerve sheath, and dura mater is closely adherent to the overlying bone. So whenever there is indirect trauma to the optic nerve, as in blunt trauma, the damage occurs in this portion of the optic nerve. Next comes the intracranial portion of the optic nerve, which is around 10 millimeter long. It lies above the cavernous sinus and converges with its fellow to form the optic chiasma. Here it is covered by the pia mater only. Optic nerve travels through the bony orbit and enters the middle cranial fossa through the optic canal. Right and left optic nerves then converge at the level of the optic chiasma. Optic chiasma is a very important structure as far as resident training is concerned, theory is concerned, practical is concerned, or whenever we see patients, this region, relations of this region and the diseases involving this region are very, very important. So I advise the residents to learn in detail about the optic chiasma region. It is a flattened structure. Dimensions are 12 millimeter horizontally and 8 millimeter anteroposteriorly. It lies above the diaphragma sella. Diaphragma sella is a portion covering the sella turcica, which is a bony cavity in the sphenoid bone. It continues posteriorly as the optic tract and forms the anterior wall of the third ventricle. Relations of the optic chiasma are very important. Anteriorly, there is anterior cerebral artery and anterior communicating artery. Posteriorly, there is infundibulum, hypothalamus, mammillary body, and the pituitary tract. Superiorly, there is a third ventricle, and inferiorly there is a pituitary gland. So chiasma lies just above the pituitary gland in 80% of the cases. So any tumor involving the pituitary gland presses the fibers which are forming the optic tract, leading to the corresponding visual field defects. Laterally, there are extra cavernous portion of the internal carotid artery. So relations of the optic chiasma are very important. Optic chiasma. In optic chiasma, fibers from the nasal aspect of the each retina decussate to the contralateral optic tract, while fibers from the temporal retina remain on their respective sides. What is important to learn from this diagram is that see, the right side of the visual field is being represented in the red color, and left side of the visual field is being represented in the blue color. We see that the right visual field, which is represented by red color, is being transmitted to the left side of the visual cortex. So there is contralateral representation of the visual field, which is very important to be learned. So whenever the stimulus is there in the right side of the visual field, it is being transmitted to the left side of the occipital cortex. Similarly, the left visual field is being shown in blue in color, and this representation will be there in the right side of the occipital cortex. So this is the arrangement of the fibers because of the decussation at the level of the optic chiasma, in by which there is contralateral representation of the visual field. So we should also know the anatomical variations of the optic chiasma. In 80% of the cases, there is central optic chiasma, which lies just below the optic tract. So any lesion involving the sella turcica or the pituitary gland will directly press the fibers of the optic tract, leading to the corresponding visual field defects. But in 10% of the cases, there can be prefixed chiasma, or in another 10% of the cases, there can be post-fixed chiasma. In prefixed chiasma, what happens is that chiasma lies just anterior to the sella turcica or just above the tuberculum sellae. So if there is any tumor involving the pituitary gland, will not compress the fibers of the optic tract, optic chiasma. Otherwise, it will press the fibers of the optic tract first. Similarly, in post-fixed cases, which generally happens in 10% of the population, the pituitary gland tumor will not press the fibers of the optic tract. It will press the fibers of the optic nerve first. So there will be corresponding visual field defect accordingly. So when the chiasma is central, it lies directly over the sella. Expanding pituitary tumor will involve the chiasma first, and if it is a prefixed tumor, it lies more anteriorly over the tuberculum sellae. So pituitary tumor will involve the optic tract first. Otherwise, on the contrary, in post-fixed chiasma, it lies more posteriorly over the dorsum sellae. So pituitary tumor damage will first damage the optic nerves first. So this diagrammatic representation is also of the same entity. In central diagram, we can see that this is a normal chiasma, which is known as the central chiasma. So any tumor of the pituitary gland will press the fibers of the optic chiasma. Otherwise, in prefixed chiasma, any tumor involving the pituitary gland will press the fibers of the optic tract first, whereas in post-fixed chiasma, any tumors of the pituitary gland will press the fibers of the optic nerve first, leading to the corresponding visual field defect. So this is entity which is to be understood in detail. So after the optic chiasma, there is the formation of the optic tract, because visual pathway continues as two distinct optic tracts, each carrying the temporal fibers of the same eye and nasal fibers from the other eye. So in optic tract, we are getting the temporal fibers of the same eye and the contralateral nasal fibers. So after the optic tract comes the lateral geniculate body. Optic tract then passes posteriorly, where most of the axon synapse in the lateral geniculate body. Lateral geniculate body is the area of the thalamus. So thalamus just lies above the brainstem. So in lateral geniculate body, there are 6 layers in which different cells are there, which are responsible for the motion, which are responsible for the position and location of different objects. One more thing, important thing at this point is to be learned is that the pupillary fibers which are coming along the optic tract, they deroot just above the lateral geniculate body and they travel to the superior colliculus at the level of the midbrain. So any lesion after the optic tract will not affect the pupillary reactions. So this is one thing which needs to be understood. So after the lateral geniculate body, there are optic radiations. Majority of the fibers pass posteriorly to become the geniculocalcarine tracts or optic radiations. They generally travel in two fibers. One are the inferior fibers. They travel through the temporal lobe and forms the Mears loop and end up in the occipital cortex. These inferior fibers are carrying the signal from the superior retina. And so a lesion involving the temporal lobe will affect the inferior fibers and the defect will be in the superior part of the visual field. Similarly, superior fibers are there, they travel through the parietal lobe and end up in the occipital cortex. So lesions affecting these superior fibers will be represented as defect in the inferior part of the visual field. As we can see in this diagram also, that at the level of the optic chiasma, these are the green fibers which are the inferior fibers, inferior retinal fibers responsible for the superior visual field. They take a loop, forms a Mears loop and end up in the occipital cortex. Similarly, red colored fibers are the superior fibers. They travel through in the parietal lobe and end up in the, they somewhere travel directly and end up in the occipital cortex. This is known as Baum's loop. And in the central part, these are the macular fibers which travel directly up to the tip of the cortex. So in this diagram, one more important thing which is to be understood is that you see here, this is a different type of arrangement of the fibers. What is happening here is that when inferior fibers are coming in one optic nerve, inferior nasal fibers are coming, they are crossing at the level of the optic chiasma to go to be transmitted to the contralateral optic tract. But before going to the contralateral optic tract, they form a genu that is known as knee of Willebrand. They form a genu at the junction of the optic nerve and optic chiasma, and then they travel to the contralateral optic tract. So any lesion which involves the junction of the optic nerve and optic tract will affect these fibers also. So this area is known as junctional area. So the scotoma which is being produced by this lesion at this area is known as junctional scotoma, which will affect the, suppose there is a lesion involving this part of the optic nerve. And so ipsilateral fibers of this optic nerve will be involved, whereas the inferior nasal fibers of the contralateral side will be involved. So that the scotoma, what we get is that junctional scotoma. We will discuss in detail, but there is a formation of a knee of Willebrand at this point. So then optic radiations eventually synapse in the primary visual cortex, which is located on the medial aspect of the occipital lobe. So this was the anatomy of the visual pathway. So now coming to their applied aspects or visual field effects. So before going in detail about the visual field effects, we should know some technical, we should be familiar with the technical terms which are being used in any neuro-ophthalmological case or any neuro-ophthalmological visual field effects. Only then we will be able to understand more easily the concept of the visual field effects. So first term is the anopia. Anopia means loss of vision in one visual field. There can be right anopia or left anopia. So complete loss of visual field in one eye is known as anopia. So similarly, hemianopia. Hemianopia is loss of vision in one half of the visual field. So it can be homonymous hemianopia or it can be heteronymous hemianopia. So homonymous hemianopia means that one side of the visual field is lost. It can be right side homonymous hemianopia or it can be left side homonymous hemianopia. Suppose a patient is having right side homonymous hemianopia. So what we will get in the perimetry? We will get the right temporal visual field not be there, visual field loss will be there on the right eye, and on the perimetry of the left eye, we will get the nasal visual field will be lost in the left eye. So on total will get the right side visual field loss. Similarly, left homonymous hemianopia will be having temporal loss of the visual field of the left eye and nasal loss of the visual field of the right eye. So this is homonymous hemianopia. Heteronymous hemianopia, when the visual field is not on one side, it can involve the temporal side of both eyes or nasal sides of both eyes. So accordingly, it will be a bitemporal hemianopia or binasal hemianopia. So there can be monoocular hemianopia also, when there is loss of only temporal or nasal visual field in one eye only. The lesion is generally prechiasmal in these cases, because homonymous hemianopia generally happens when the lesion is after the chiasma, or the lesion is generally post-chiasmal. Next term which is to be understood is congruous or incongruous defects. Congruous defects we label when the defects are identical in size, shape, location, and margins. When we can superimpose these effects on both the eyes, you can better understand in that way. These defects generally appear when the lesion is after the optic radiation area. Incongruous defects are defects which are not similar or they are dissimilar. We cannot superimpose these defects on each other. They happen when the lesion involves the optic tract or LGB lesion. As you can see in this diagram, these are the congruous defects. These are the incongruous defects. So quadrantanopia is another term which is self-explanatory. Loss of vision in a quadrant of the visual field. They can be superior quadrantanopia when superior part of the visual field or superior quadrant of the visual field is involved, or inferior quadrantanopia when inferior part of the visual field is not involved. It will be homonymous when one side or one part of the superior side is involved on the similar in both the eyes. It will be superior homonymous quadrantanopia or inferior homonymous quadrantanopia. So one more important thing is to be understood is that visual fields and retina have an inverted and reverse relationship. It means whenever fibers coming from the inferotemporal retina are involved, whenever any lesion which involves the fibers coming from the inferotemporal retina, the defect will be in the superonasal part of the visual field. Inverted and reversed. Inverted means that from inferior to superior, reverse means from temporal to nasal. So whenever there is any lesion which involves the fibers coming from the inferotemporal retina, the defect will be in the superonasal part of the visual field. Similarly, whenever there is any lesion which is involving the fibers coming from the superotemporal retina, the defect will be in the inferonasal part of the visual field. Accordingly, whenever there is any lesion involving the fibers coming from the superonasal retina, the defect will be in the inferotemporal part of the visual field. And accordingly, whenever there is any lesion involving the fibers coming from the inferonasal retina, we see the defect in the superotemporal part of the visual field. This is very important in localizing where exactly the defect is, because when we do perimetry, we will see the printout, we see the defect is there, but accordingly we can localize the lesion, that where can be lesion in the visual pathway. So now coming to the lesions at the visual pathway. So where can be lesion? Lesion can be anywhere in the visual pathway. So starting from the optic nerve can be involved. Then at the junction of the optic nerve and optic chiasma, there can be lesion. Lesion can be at the level of the center of the optic chiasma, or lesion can be at the lateral part of the optic chiasma. Next is the optic tract. So optic tract can be involved. Lateral geniculate body can be involved. Optic radiations can be involved. Occipital cortex can be involved. So lesion can happen at different levels of the visual pathway. So we can localize the lesion by doing perimetry and exactly amounting the calculating the amount of the defect. So first of all, we will discuss the field defects involving the lesions of the optic nerve. So as we all know, optic nerve can be involved in traumatic cases. There can be traumatic avulsions of the optic nerve. There can be traumatic optic neuropathy, or there can be any cause of the optic atrophy. So we will get the clinical features like there will be ipsilateral anopia. There will be loss of direct pupillary reaction and loss of consensual pupillary reaction. Means what is pupillary reaction? Pupillary reaction is that when we put a light on a patient's eye, there will be brisk reaction to the pupil. But whenever the defect is involving the optic nerve, there will be no constriction of the pupil. Accordingly, there will be no constriction of the consensual eye also. So on the doing the perimetry, we will get a scotoma, complete loss of the visual field in one eye. If there is involvement of the right side, that will be right anopia. If there is involvement of the left side, there will be left anopia. So this is how we can get that where is exactly is the visual defect by calculating the visual field defect and by analyzing the clinical features of the patient. Next come the lesion at the level of the junction. As I told, at the level of the junction of the optic nerve and the optic chiasma. Now, what is happening at the level of the optic junction of the optic nerve and optic chiasma? That there are small fibers of the inferior nasal retina which are forming a genu and forming a knee of Willebrand. So we get a junctional scotoma. In junctional scotoma, there will be a central scotoma in one eye and superotemporal visual field defect in the other eye. Why superotemporal? Because the fibers which are involved are the inferonasal fibers, and these inferonasal fibers are responsible for the superotemporal visual field. So we get a central scotoma in one eye and superotemporal visual field defect of the other eye. So accordingly, we can get to know that where can be the lesion. So lesion is at the level of the junction of the optic nerve and optic chiasma. So ipsilateral optic nerve at the junction and also the contralateral crossing inferior nasal retinal fibers are involved. So in that way, we can get to know that where is exactly is the lesion. So now next after the optic nerve is the optic chiasma. So there are different lesions which can involve the optic chiasma. Most important is the pituitary adenoma or malignancy, craniopharyngioma, chronic chiasmal arachnoiditis. There can be fracture of the base of the skull. So all these lesions can press the fibers which are forming the optic chiasma. So what is there in the optic chiasma? In the optic chiasma, the nasal fibers of both the eyes are decusating. Accordingly, if these fibers are being damaged, the defect will be bitemporal hemianopia. So classical bitemporal hemianopia will be there in cases of pituitary macroadenoma or malignancy. There can be less common, but there can be binasal hemianopia also in lesions involving the optic chiasma whenever there is enlargement of the third ventricle, dilatation of the third ventricle, or atheroma of carotids or posterior communicating arteries. Though these type of visual field defects are less common, bitemporal hemianopia is more common whenever there is a lesion involving the optic chiasma. So this is one case in which 55-year-old female presented with for consultation of prescription of the glasses. There is a low bilateral visual acuity which is there for the last 6 months. Patient is not giving any history of headache. There is no endocrine dysfunction. Visual acuity was decreasing in both the eyes. Ophthalmological examination, what was being done was almost normal. So when we did a visual field defect, there is a bitemporal hemianopia. So after seeing the bitemporal hemianopia, neuroradiological investigation was being ordered and brain CT scan revealed a homogeneous intracellular mass lesion. So what we get from this case is that we should do a visual field examination whenever we are suspecting any neuro-ophthalmic cause or whenever we are not getting what is the cause of less vision. We should do a visual field examination, and accordingly, if we are getting the visual field which are corroborating with the neuro-ophthalmological cause, we should order a neuroradiological investigation, and we will not miss any serious cause leading to the visual field defect. Now coming to the optic tract, there are different lesions which can lead to the defects, visual field defect of the optic tract. The common causes are syphilitic meningitis, tuberculous meningitis, tentorial meningioma, aneurysm of superior cerebellar or posterior cerebral arteries. Clinically, we get a contralateral hemianopic pupillary reaction. And what is that? It is that when we show a light to the pupil, only the part which is not involved will be constricted, rest pupil will not be constricted. That is known as Wernicke's pupil or Wernicke's reaction, and visual field defect will be homonymous hemianopia. So this is a case of 53-year-old healthy woman which complained of difficulty reading and progressive blurring of vision over the last 4 weeks. No headache or any pain. Visual acuity was mildly decreased to say 6/9 in both the eyes. RAPD was there on the right side. When we did a fundus examination, we see a temporal pallor of the optic disc, and on visual field assessment, we get an incongruous homonymous hemianopia. After seeing this type of visual field, we ordered a MRI, and contrast MRI revealed a contrast enhancing lesion on the area of the optic tract. So in that way, that patient was being managed. Next comes the lateral geniculate body. So lateral lesions involving any part of the lateral geniculate body will lead to congruous or incongruous homonymous hemianopia. There will be sparing of pupillary reflexes because the pupillary fibers which are responsible for the pupillary reflex, they deroot before the lateral geniculate body, and they go to the area of the superior colliculus in the midbrain. So we will see normal pupillary reflex in the lesions involving the lateral geniculate body. So lesions affecting the anterior or lateral choroidal arteries may affect the lateral geniculate nucleus, and isolated lesions of the lateral geniculate nucleus are very rare. No optic atrophy is there, as first order neurons have already synapsed in lateral geniculate body. So this is the case of 62-year-old male presented with severe headache and visual disturbance. On examination, blood pressure was very high. Neurological examination was normal except for the visual fields. Neuro-ophthalmological examination showed a normal visual acuity, normal pupils, normal ocular motility, and normal fundus. Visual field defect shows congruent homonymous hemianopia. Brain CT scan disclosed an ischemic lesion of the lateral geniculate body, which was enhancing by contrast. So the problem was the patient was developing all these because of the high blood pressure. Next comes the lesion involving the optic radiations. So as we already discussed, the Mayer's loop was being formed in the temporal lobe, which extends up to the occipital cortex. This is responsible for this carries the inferior nasal fibers, and these inferior nasal fibers, when they are involved, the defect will be in the superior quadrant. So the defect will be homonymous superior quadrantonopia. It is also known as pie in the sky. So in inferior fibers which are there in the Mayer's loop, which travel through the temporal lobe, and any lesion involving this area will lead to superior quadrantonopia. Similarly, the superior fibers which are traveling through the parietal radiations, the defect, any lesion involving the parietal lobe will lead to inferior quadrantonopia. And the superior quadrantonopia is also known as the term pie in the sky, and inferior quadrantonopia is also termed pie on the floor. So we will get this type of visual field defect. The common causes which can lead to these type of visual field defects are the vascular occlusions, cerebral tumors, or whenever there is injury by fall on the back of the head. Next comes the visual cortex. So optic radiations eventually synapse in the primary visual cortex. So primary visual cortex is richly supplied by the posterior cerebral artery and middle cerebral artery. So the central diagram shows the macular sparing homonymous hemianopia. So how we get this type of picture? Because in the macula, there is a good supply by the middle cerebral artery and the posterior cerebral artery. So whenever there is a PCA infarct, the macular sparing defect can be there. This is a type of homonymous hemianopia, which is macular sparing. It generally happens in the PCA infarct. There can be central homonymous hemianopia also whenever the macular portion, which is being represented in the occipital cortex, is being damaged by any gunshot or any trauma to the head. Then we get this type of central homonymous hemianopia in which only macular fibers are being damaged. In all these cases, pupillary reflexes will be normal. There will be no optic atrophy, and contralateral temporal crescentic defect can also be there when anterior most part of the visual cortex is being damaged, because the inferior fibers are being represented in this part of the visual cortex. So common causes which can lead to these type of visual field defects are the vascular lesions in the territory of the PCA, trauma when there is fall on the back of the head, or gunshot injuries, primary tumors, cerebral tumors, or metastatic tumors. Now we'll discuss few cases which presented to us. So first case is of a 69-year-old male which presented with gradual, painless, progressive diminution of vision in the both eyes. Visual acuity was 6/36 in both eyes. When we did a visual fields, so there was bilateral temporal visual field defect in both the eyes, or bitemporal visual field defect. Optic disc shows pallor on both eyes. MRI was ordered. MRI revealed supracellular cystic solid lesion compressing the optic chiasma. So as we can see here, so this is a classical case of craniopharyngioma which presented with a bitemporal hemianopia. So patient presented to the ophthalmology OPD. So it is our duty to examine the patient in detail, to do the visual fields. Whenever we get this type of visual field which are corresponding to the neuro-ophthalmic visual fields and corresponding to the vertical apical meridian, we should order a neuroradiological investigation so that no disease should be missed and patient should be properly treated. This is again a 25-year-old female presented with gradual, painless, progressive loss of vision in the both eyes. Visual acuity in the right eye was 6/36, in the left eye was 6/18. Visual field again showed bitemporal hemianopia. Fundus was having optic disc pallor, which is more in the right eye as compared to the left eye. Again, MRI revealed, you can see this scan of the MRI, intracellular mass with upward displacement and compression of the optic chiasma, and most commonly this lesion was the pituitary adenoma. So these cases should not be missed. These cases generally land up in the ophthalmology OPD only. So this again a 60-year-old male presented with sudden vision loss with headache. Best corrected visual acuity was 6/12 in the right eye, 6/9 in the left eye. Fundus was normal. Visual field showed complete left homonymous hemianopia. MRI revealed ischemic stroke in the posterior area, posterior cerebral artery distribution serving the right occipital lobe. So this was a case of occipital lobe infarction. So this is again a 34-year-old female presented with sudden vision loss with headache. Best corrected visual acuity was 6/12 in the right eye, 6/9 in the left eye. Fundus was almost normal. So visual field showed incomplete superior quadrantanopia. So we ordered MRI. MRI showed temporal lobe infarction. Now superior quadrantanopia again represented by the inferior fibers which are there in the temporal lobe, so forming the Mayer's loop. So this was a case of temporal lobe infarction. So this is again one more interesting case of a 62-year-old male presented with sudden onset blurring of vision in both the eyes. Visual acuity was 6/9 in both eyes. Pupils were normal. Fundus was normal. Visual field showed congruous right homonymous hemianopia with macular sparing. And MRI showed left parieto-occipital stroke sparing the occipital tip because of the good blood supply of the occipital tip. So this was a case of macular sparing congruous homonymous hemianopia due to occipital lobe infarction. So thank you very much.
Thank you, sir, for the wonderful lecture. You have covered almost all the points about visual field and the defects associated with visual fields. There were some of the concepts which the students want to know again. So and they are commonly asked also in the exams. One thing which I would like to add is that if you are giving any exam like FICO or FRCS, these questions, one of these questions is definitely you'll find in your question paper that will be there. So, sir, if you can, someone is asking about what was the difference between the congruous and incongruous defects.
Congruous defects, as I told, that these are the identical defects. Identical defects means that they can be superimposed on each other. The two eyes are having similar type of defects. These are similar in size, shape, depth, margins, slope of the margins. So these happen when the fibers are close to each other. So incongruous defects are defects when they cannot be superimposed on each other in two eyes. The defects are dissimilar in the two eyes. So they are different in size, different in shape. So they are not similar. So that generally happens when the fibers are not close to each other.
Yes. And I think junctional scotoma is another question. What junctional scotoma? They want to understand junctional scotoma again.
Okay. So I will make them understand in detail that what is junctional scotoma. Junctional scotoma is a defect. It is being produced when the lesion is at the level of the junction. Which junction? Junction of the optic nerve and optic chiasma. Now, what is happening at that junction? At that junction, nasal fibers of one eye are going to the contralateral side, and temporal fibers are not crossing. Temporal fibers are going to the ipsilateral side. So, when nasal fibers of one eye are going to the contralateral optic tract, they just form a genu in the contralateral optic nerve. before going to the contralateral optic tract. So at the level of the junction of the optic nerve and optic chiasma, there is a formation of a genu of the inferonasal fibers of the retina. So inferonasal fibers of the retina, they do not directly go to the contralateral optic tract. Before going to the contralateral optic tract, they just go to the contralateral optic nerve, and then after forming a genu, they go to the contralateral optic tract. So that genu is known as the knee of Willebrand. So whenever there is a lesion in that part, what will happen? Whenever the lesion is there in that part, the ipsilateral optic nerve will be involved, and the fibers which are forming that knee of Willebrand will be involved. Now, so what were those fibers? These fibers were the inferior nasal fibers of the contralateral eye. So these were the inferior nasal fibers, and they are represented by the superotemporal visual field. So whenever the defect is there in that area, what will happen in the visual field? There will be complete loss of the visual field of the ipsilateral side of that particular optic nerve which is being involved, and on the same time there will be defect in the other eye which is being produced by the lesion of the inferonasal fibers which are being involved, and they are represented in the superotemporal part of the visual field of the other eye. So what we get in the printout, what we get in the finally visual field, we get a complete loss of visual field of the ipsilateral eye along with the superotemporal part of the loss of the visual field in the contralateral eye. So this is known as junctional scotoma.
Yes, sir, very nicely explained about junction scotoma. And I think you have covered almost all the topics, and there are no further questions. Specific syndromes of occipital cortex, I think that will be discussed in separate class. So I think we have covered everything. Do we have?
So Gunjan,
Yes, sir.
you have seen that group, no?
Yes, sir.
If there are no further questions, then we can conclude here. Thank you
Yes.
so much, sir. It's a very
Okay,
difficult topic, but your flow was so nice. No, it's very easy for a student to understand.
Okay, Prabhu.
And for
Thank you so much.
students, this is very important topic because you
Yeah.
will get it in your grand viva, black
Yeah.
box. Wherever you go, this question will be definitely asked to you.
Yeah.
And one mistake that most of you do is you go into too much detail, but examiner doesn't have that much time. So whatever sir just taught you in the class, just mug up this much, and that will help you in your exam. Yes,
Okay.
Panta, you have to say something, I guess.
Okay.
So sir, this is a certificate for.
Okay.
Yes, so we'll give you this as a frame certificate in our
Okay.
annual DOS,
Okay,
which is next year, 24 to 26 April.
okay.
And I hope you'll join us
Sure.
for that
I'll
program.
definitely come. Whenever you say, I'll come.
Well, then thank you so much, sir. And I think Gunjan, you can conclude.
Yes.
Okay.
So thank you. That was all about the visual field effects, which have been very well covered by sir. And I think, sir, if we can get are we collecting PDF for this lecture as well? Rahul, sir?
You want?
Yes, sir. Actually, they collect PDF for the PPTs, and that is shared amongst the postgraduates.
I will send to Dr. Praful.
Yes. Either Dr. Praful or Dr.
So, sir,
Tanvi.
what we are doing, sir, once this NEURO-OPHTHAL module is over, we'll compile the PDF of all the talks.
Sure. I'll
and
give you.
share with the student. So that will help them to revise.
Okay, Dr. Praful, I'll give it to you.
Thank you, sir.
Okay, thank you so much. Thank you, Dr. Paneet.
Thank you,
Dr. Paneet.
Thank you and good night all.
Okay, thank you. Okay, bye.